Welcome, everyone. The left picture was yesterday morning, looking out the window when I got up. What the picture doesn't show you that it was -9. So we're still in the middle of winter, and I just looked up, our first snow was October 14. So you can imagine it's not too difficult to come out here, at least trying to, for as long as the airplanes actually are leaving. And so we're lucky. Today they have another storm, so hopefully I can get back tomorrow afternoon. But this is here now, so we enjoy this, and I hope you enjoy it too and have some time to enjoy it this afternoon. We're going to cover a few things, and many of the terms that we're going to be talking about have already been introduced by Dr. Warrington and by Dr. Carton-Sierra. I'd like to get a little bit of a feel for this audience as we go along, and hope to be able to engage you a little bit. How many of you are patients? So that's about half. And the other half are relatives, friends, and loved ones, I presume? All right, this is great because, as you know, the patients need your support, and we all need to learn about the disease. How many of you have what we now call GPA or Wegener's? Okay. How many have microscopic polyangiitis? And how many have EGPA or Churg-Strauss? And how many have giant cell arteritis or Takayasu's? Okay, so most of you have ANCA-Associated Vasculitis, and until very recently, when new trials have also been conducted in giant cell arteritis, until recently, over the last decades, most of the research has indeed focused on ANCA-Associated Vasculitis, GPA, MPA, and EGPA. I will present mostly on GPA and MPA. I leave EGPA out because we're going to have another presentation on EGPA and asthma and the biologics as a dedicated presentation, and I'm sure we have room for questions and answers in that context. So when we talk about advancing treatment, there are a lot of terms that we throw around to assess how well we're doing and how well the patient is doing. And we need to understand what we're talking about so that we can communicate appropriately. So when we measure treatment trial results or advances, we first of all, of course, focus on survival. But survival has come a long way since the introduction of treatment for Wegener's granulomatosis or GPA. But survival is still an issue, particularly very early after diagnosis and when the disease is rip-roaringly active. We talk about remission, and remission is a term that we stole from the oncologists, and the term implies that we still cannot cure the disease. We can control it, we can calm it down, we can quiet it down, but it is still lurking in the background. Now, we talk about inducing remission with treatment, and then we talk about maintaining remission. But what does remission really mean? And this is a very frequently asked question by you all when you're in the office and you say, how do I know that I'm in remission? Well, primarily, remission means that we cannot detect any disease activity, and by disease activity we usually mean inflammation that we can measure with our tests. So inflammation of vessel walls that we can see on imaging studies. Elevated markers of inflammation that we can find in the blood, like the sedimentation rate or the C-reactive protein, or other signs of active inflammation. And of course, we are dependent on the tools we use to detect inflammation. And we'll get back to that a little bit, because very often you will feel inflammation in the background, even though we cannot detect it quite yet. So remission generally means absence of disease activity. But remission does not necessarily mean absence of symptoms. And it certainly doesn't mean that you're feeling normal or back to normal when we say you are in remission, because, and this concept has already been related to you this morning by Dr. Carton-Siba and Dr. Warrington, damage is often left behind after the inflammation has been adequately treated and subsided. Damage is residual organ damage that's left behind through scarring or loss of function. And one of the major goals of treatment is not only to induce remission, but really to prevent the damage as effectively and as quickly as possible, and prevent recurrences of the disease, because as you've seen in one beautiful slide of Dr. Warrington earlier, the more disease flares you have, the more likely you are to accumulate damage. So the focus is first to have the patient survive, then to minimize damage that occurs in the acute phase of the disease, get the inflammation under control, and then prevent it from recurring. And at the same time, we also want to prevent damage that comes from the drugs that we use to treat the inflammation. And we've come a very long way over the last few decades, and I will introduce you to what we call survival curves, because when we talk about treatment trial results, or when we do research and do comparisons between one treatment versus another, we very often disseminate the results or describe the results in plots that look like these. So let's spend a couple of minutes on how to read these. So usually you have the survival rate on the y-axis here. 100% of patients are alive up here. And as time goes on, patients unfortunately die. And the more patients die, the lower the curve gets. And usually there is a comparison over time, and the comparison is either a normal population or another treatment. And this slide actually tells us how we have done over the last few decades. It's a population-based study based out of England, and it shows that patients with GPA from 92 to 13 had an increased mortality compared to the general population. But when you divide these patients up into the early decade, which is the red curves, there is quite a discrepancy between the normal patients' mortality over time and the patients with GPA. But 10 years later, the decade from 2003 to 2013, the mortality has improved dramatically. And we see the same thing over time in patients who are hospitalized in the United States with GPA. So in 1993, there was a 9% mortality rate of patients admitted to the hospital with GPA, acute disease flare, or a complication thereof. But over time, this has continued to drop dramatically. So we are getting better at treating the patients. And actually, if we did a recent population-based study in Olmsted County, the home of the Mayo Clinic in Minnesota, and we found there that the longevity or the mortality of patients with GPA is actually no longer different from patients, from normal control patients. Unfortunately, the mortality of patients with MPA and EGPA is still a little bit higher than the general population. And that is explained by patients with MPA generally being much older to start with than patients with GPA on average, and usually they have advanced renal disease when they're diagnosed. And it is important to keep a focus on renal disease, as you will see later on in my presentation. Now, this is another one of those curves, and it summarizes the results from European treatment trials over the 1990s and early 2000s. And the message here is that there is an important drop in loss of life in the first year. And half of these patients that die in the first year do not die of the vasculitis, but they die of the treatment complications, particularly severe infections. So severe infections are very often the result of the treatment we use to control the disease activity early on. Now, the other important factor to keep in mind is what happens to the kidneys early on during the disease. Here's another study out of the Netherlands that shows that if patients have no renal involvement, they overall do very well. And if the renal involvement remains mild, so that they don't end up on dialysis, then their overall survival is very good also. However, if the renal function is lost quickly, or the disease is not recognized in time to salvage renal function, and there is significant loss of renal function by 6 months, then the overall prognosis of the patients is much worse. So what really determines the long-term renal outcomes is the renal function at 6 months and whether patients develop renal relapses. So in the context of ANCA-associated vasculitis, we are focusing very closely on what's happening in the kidneys. And that's why many of you, even when you're in remission, may be monitoring your urine for microscopic blood so that we can get on top of any disease flare in the kidney as early as possible. So overall, not only key to better survival, but also key to better overall outcomes is really the early diagnosis, the preservation of renal function, and the prevention of serious infections. And in the context of prevention of serious infections, there are really two major things that we focus on. One is to use less glucocorticoids and to prophylax against potential infections. So we want to prophylax against pneumocystis pneumonia. We want to apply vaccines whenever we can so that you are protected as best as possible. Now, unfortunately, in that context, rituximab doesn't allow for the vaccines to be successful. So when you're on rituximab treatment, we have to find a window where your B cells have reconstituted so we can apply the vaccine, because the vaccines will only work when you have B cells. If the B cells are gone from the rituximab, the vaccines will not be effective. So the unmet need and open questions for ANCA-associated vasculitis today are as follows, and these are being addressed by a variety of clinical trials that are in various stages of progress. So our opportunities are clearly that we still have room to improve the very early mortality of the disease. And we need to minimize the toxicity that comes from the drugs, particularly the high-dose glucocorticoid toxicity, which contributes majorly to the early mortality that we still see. The focus is, of course, on minimizing tissue damage, and particularly the renal damage, and we'll talk a little bit about the potential tools that we have to do that. What about plasma exchange? Anyone in the room has received plasma exchange at any time? Okay, there's a handful. We'll talk about this and how we think about this today compared to 10, 15 years ago. And then there are novel drugs that hopefully allow us to get by with less steroids, and we'll talk about this. And then, of course, there are opportunities for remission maintenance. We can very effectively keep patients in remission in this day and age, and we'll talk about the role of rituximab in remission maintenance. But the big question is, does everyone need remission maintenance, or are there patients who can get by without immunosuppression for long periods of time without relapses? Well, let's talk about plasma exchange that we mentioned it. So there was quite a bit of enthusiasm about plasma exchange for potentially helping to improve the early survival by helping, in addition to standard treatment, to remove pathogenic components or things that contribute to inflammation in the acute phase, removing them by washing the blood, in essence. And this enthusiasm goes back to one large study that was done in Europe, actually in the late 1990s, where patients with severe renal disease received prednisone and Cytoxan, and then on top of that, by the luck of the draw, we call that randomization, half the patients received intravenous pulse high-dose steroids, the other half received plasma exchange. Nowadays, in the very acute phase, when the patient is in the ICU, we give high-dose steroids to everyone. So this trial design is a little different than what we would do now currently. But at the time, this trial showed very convincingly that the patients who received plasma exchange had a much higher survival and likelihood of not being on dialysis at 3 months compared to the patients who received intravenous pulse methylprednisolone. However, this enthusiasm didn't last, because when you look at the more long-term outcome of these patient groups, you can see that this advantage was only very early on, but as time went on, this advantage was lost. And that raised questions on whether plasma exchange is really as helpful as we think it is, or whether it potentially is an invasive, expensive procedure that also has some side effects. And because of this, particularly this analysis, the FDA in the United States and government agencies all over the world said, we need to study this. And as a result, they funded the plasma exchange and glucocorticoid dosing in ANCA-Associated Vasculitis trial, or the PEXIVAS trial. So we're going to talk about trials and trial results and the importance of clinical trials. So let me ask you, how many of you have participated in a clinical treatment trial? Quite a few. Anyone participated in PEXIVAS? No one in PEXIVAS. Anybody participating in other clinical research studies, longitudinal trials, longitudinal studies? Well, thank you for participating in studies, because the advances that we've seen over the last few decades really only were possible through your participation in clinical trials and clinical research. Without patients volunteering for participating in trials, the field will not move forward. So this is actually the largest study that was ever done in ANCA-associated vasculitis. 700 patients were enrolled all over the world with severe ANCA-associated vasculitis, and this trial has been completed, and the results have been presented at meetings and are under review for publication in peer-reviewed journals. So these patients with either alveolar hemorrhage or renal disease were all receiving standard treatment with glucocorticoids and either cyclophosphamide or rituximab. And then they were randomized to receive either plasma exchange in addition to this standard treatment, or no plasma exchange. And then there was another subgroup. Remember, we are all very nervous about giving as much steroids as we do because we see the high infection rate early on. So there is a focus in the community to really bring down the cumulative steroid dose as much as we can. And this focus made it into this trial design. So in addition to plasma exchange versus no plasma exchange, the patients were randomized to receive either our customary standard glucocorticoid regimen, which is relatively high, versus a more accelerated tapering regimen or a reduced dose glucocorticoid regimen. And we did the same randomization for the patients who received no plasma exchange. And then the primary outcome was survival or survival of the kidney. So the patient could, how many deaths or how many patients on dialysis is what was counted as the combined outcome of this trial. Because remember, that was the primary outcome of the first study that showed an advantage for patients receiving plasma exchange. Now, I'd like to just give you the headline summaries because these are really important and will change how we treat patients with severe ANCA-associated vasculitis in the early remission induction phase. So there was absolutely no benefit to plasma exchange when you looked at the entire cohort as a whole, or when we analyzed the patients who had severe renal disease or the patients who had alveolar hemorrhage bleeding into the lungs that Dr. Kartensiba had described earlier. So really, the enthusiasm for plasma exchange has been waning very rapidly. And I think once the trial results will be published in the peer-reviewed literature, insurance companies will probably clamp down, so the use for plasma exchange will be very, very restricted. And we have no longer any meaningful data to support its use. The other major treatment-changing outcome of this trial was that the efficacy of the standard glucocorticoid regimen compared to the lower glucocorticoid regimen was exactly the same in terms of efficacy of inducing remission. So no fewer patients went into remission. Patients did not go into remission slower if they received less glucocorticoids. So that really tells us, historically, we've been erring on the more is better side, and we probably do harm with this. So we are taking serious looks at avoiding glucocorticoids going forward. And the other more important message is really, yes, there were fewer infections in the patients who received less steroids. So not only was it the same efficacy, but there was actually a significant benefit in terms of saving patients from infections. So going forward, we will undoubtedly give less glucocorticoids than we have in the past. Now, we still can't do completely without it, don't get me wrong, but another trial that I'll talk about in a couple of minutes will hopefully contribute to further reducing the steroid dose. We have evidence from other sources also, not from a clinical trial. Dr. Kartensiba, when he was still in Rochester, looked at our Mayo Clinic series of patients with alveolar hemorrhage caused by ANCA-associated vasculitis. Is a subset of patients that very frequently ends up on the respirator because they're bleeding into the lungs acutely, and that is a group of patients where plasma exchange has been very popular. And so we looked at our Mayo series, and within the Mayo series, even when we adjusted for the severity of disease, we found no benefit for plasma exchange. And when Dr. Kartensiba summarized all the patients in the literature where one could assess from the literature whether they had resolution of their alveolar hemorrhage and survived the hospitalization, whether they received plasma exchange or not, there was really no significant difference in resolution of alveolar hemorrhage and being able to leave the hospital, whether they received plasma exchange or not. So even from that series, uncontrolled series, it seems that for patients with alveolar hemorrhage, there is no advantage for using plasma exchange. And we have now also looked at patients with severe renal disease in our Mayo cohort, some 270 patients that will be presented at the upcoming ANCA meeting. And again, in that subset of patients, we also found no benefit of plasma exchange. So I think the chapter of plasma exchange is rapidly closing. Now, what about inducing remission without steroids altogether, or with very, very little steroids, maybe for a week? Well, that is really the hope of coming with new drugs, particularly avacopan. And avacopan is a drug that targets a specific pathway in the active inflammation early on. It targets the complement activation pathway that leads to neutrophil recruitment and neutrophil activation. And don't focus so much on this slide, just listen to the main message that's behind that slide. I know it's complicated. The avacopan story is really a testament to combined efforts of basic research leading to new drugs. The understanding of the complement pathway and allowing us to even look at it as a potential target for intervention comes out of seminal laboratory-based research, particularly from the Chapel Hill group in North Carolina, Dr. Charles Jeanette and Dr. Falk's group. They had an animal model, mouse model of MPO ANCA-Associated Vasculitis, and in that mouse model, it was able to dissect various pathways, and from that mouse model, the observation became clear that the complement pathway, the activation or the interaction of complement factor 5 with its receptor was crucial in the development of the small vessel vasculitis in mice. And the company had a small molecule agent that blocked the interaction of activated complement factor 5 with its receptor. And this agent was then taken into clinical studies, first phase 1 studies and then phase 2 studies. And I will show you the results from the phase 2 studies that generated the enthusiasm about why we would think about this agent more broadly. So the first small study in 60 patients was conducted in Europe, and the patients either received the high-dose steroid use as normal, or they received avacopan, which is the new drug, with low-dose steroids, or avacopan and no steroids at all. And on this y-axis here, you see the Birmingham Vasculitis Activity Score, which is a scoring system we use in clinical trials to measure disease activity. It's a standardized tool, and the authors of this study looked at the reduction of disease activity over time in the first 12 weeks. And this is a small study, 20 patients only in each group, but the signal was quite clear that there was really no statistical significant difference in the improvement of disease activity in the first 12 weeks between the 3 treatment arms. If anything, there was a trend that the disease activity improved quicker or better in the first 12 weeks than with the standard treatment arm. So that was hope number 1 that came from this pivotal, or from this important first trial. The other thing that came out of this trial was looking at the marker of early renal damage. And keep in mind that I told you earlier that how well your kidneys are functioning at month 6 determines your overall outcome of the disease. So maintaining as much kidney function as possible early on is crucial to improve the overall outcomes of the patient's disease over time. And there is a marker of early renal damage that is called the urine albumin creatinine ratio. They measure albumin, they measure creatinine in urine, and the ratio of it is a marker for early renal damage. And the patients who received the drug had a very significant early reduction over the first week of this marker of renal damage compared to the patients who received the steroids. So there is hope that we can intervene and improve renal inflammation more quickly, saving damage early on with this new agent. And these data got everyone so excited that the phase 3 randomized controlled trial was designed that really compares head-to-head steroids to avacopan in a blinded fashion on top of standard treatment, consisting of either cyclophosphamide or rituximab. So the trial has completed enrollment of the target patient population of 300 patients, and we eagerly anticipate the results by the end of this year or in the fall. So this can be potentially the second major game changer after rituximab replaced cyclophosphamide pretty much. This may be a pathway that can get us away from having to rely on very high-dose steroids early on during the disease phase. So we'll see what the side effect profile of this drug will be. We'll see how well it preserves renal function. We'll see how well it induces remission, and we eagerly await the results. Now, there are other drugs, or at least one, that is also looking at this same pathway. It's a different molecule. So there is another trial that will come about pretty soon, looking for patients to enroll, that also hits this same pathway. So there is great hope that we can do with less steroids going forward. So a couple of words on remission maintenance before I close. Why maintain remission? Well, and how to maintain remission. Why is clear, we want to prevent damage. How? There are various ways of doing it. But ultimately, it's always about the balance of the risk of relapse and its resulting cumulative damage or its resulting cumulative steroid exposure versus the risks associated with keeping patients on remission maintenance drugs such like azathioprine or methotrexate or rituximab in this day and age. So rituximab has recently been approved by the FDA for remission maintenance. And this goes back to the results of a trial that was conducted in France that compared rituximab to azathioprine or Imuran for remission maintenance after remission had been induced with the combination of glucocorticoids and cyclophosphamide. And this trial showed unequivocally that the patients who received rituximab had a much lower occurrence of severe relapses compared to the patients who received azathioprine. And the authors also did a cost-effectiveness analysis that was presented at the last ANCA meeting in Tokyo in 2017. You would think, well, rituximab is so expensive, how can this be cost-effective if we give it for long periods of time when we have a much cheaper drug like azathioprine that's been around for decades? Well, it turns out that if you more effectively prevent relapses, you essentially prevent renal relapses and you prevent patients ending up on dialysis and all other complications that come with subsequent relapses, which are tremendously costly to the healthcare system. So when we talk about what does a treatment cost, I think as a society and as an advocacy group, the Vasculitis Foundation also could play an active role in advocating for looking at the overall cost of treatment that comes with a certain treatment so that we get a way of comparing the dollar cost of one drug versus the dollar cost of another drug and ignore everything else. So I think this is where, having better tools for data analysis and being able to analyze large patient populations in the background through new computational tools will hopefully give us some meaningful answers of how we can better take care of patients over time by looking at the overall cost of a certain treatment. The Retazoram trial, some of you may have participated in this. It was conducted in the US, compares also rituximab to azathioprine. It's a different dosing regimen, different intervals of treatment that were used. The Retazoram trial is done only in patients who have a history of relapses and only in patients who had remission induction with rituximab, not with cyclophosphamide. So slightly different patient population, slightly different questions asked in the trial, but this trial also addresses the question whether we're giving too much steroids early on, because during the induction phase of this trial, there were two prednisone dosing regimens, one the standard and one the lower. So this trial will also give us an answer to the question of whether we have historically been giving too much steroids and whether we can get by with much less. So we anticipate the results from this trial also later this year. So how can we improve on giving everyone effective remission maintenance therapy? Well, we need to identify the patients who really need it, and then we need to have biomarkers that tell us when a relapse is more likely or when the relapse is not that likely. And in that context, you, the patients, are probably the best biomarkers. And we need to listen to you because you are very often able to tell us that a relapse is impending, even though we cannot measure it quite yet. And we actually have data from this, and this is very important data that was a sideline study that was done in the context or after with the data of the Wegener's granulomatosis etanercept trial, or the WIGET trial, which was done in the early 2000s. And in this study, all the patients completed a so-called physician global assessment score. So the patient said, we asked the patient, how do you feel? Do you think your disease is active? And you mark on a scale of 0 to 10 where you're at. And it was quite sobering for us that, yes, we can determine the relapse at the relapse visit. And yeah, not surprisingly, your patient global assessment score went up significantly by the time we were able to diagnose the relapse. But the patient global assessment scores already went up significantly at the visit prior to the visit where we as physicians with our tools were able to determine that you had a relapse based on seeing active inflammation again. So the lesson in this for us as physicians is, as always, listen to the patients. And if you tell your physicians, I'm having the same migratory large joint pains again, or my teeth are aching again like they did when it all started, or my scalp is tender again like I had when it all started, we better listen to that and factor this in our decision-making process. Now, we now know that not all patients are equal in this big bucket of ANCA-associated vasculitis. And the relapse risk is quite different depending on whether you're diagnosed with GPA versus MPA or whether you have PR3 ANCA versus MPO ANCA. So, and this is just one set of data from the RAVE trial that looked and separated the groups into patients who were diagnosed with microscopic polyangiitis, had MPO ANCA and a new diagnosis, and those patients have a very low relapse rate. So if you're newly diagnosed with MPO ANCA positive microscopic polyangiitis, your relapse risk is very low, and you may not need immunosuppression long term. However, you need to be monitored because you could develop a flare, and then we need to get on top of it as quickly as possible, because once you've had a flare, you fall into the group of having had a relapse, And that in and of itself is another major factor predicting subsequent relapses. Now, the patients who are at very highest risk for relapse are the GPA patients with PR3 ANCA who've already had a flare in the past. And those patients probably need to be on some form of immunosuppressive prevention therapy long term. Now, how to do that and how we can determine in this context how to do it, ANCA, particularly PR3 ANCA, can help us quite a bit, mostly in patients who have been treated with rituximab in the past. That is the patient population where looking at PR3 ANCA serially works the best. And at Mayo, we've generally done this following B-cell counts and ANCA levels. And for as long as the B-cells are gone and the ANCA is negative, the patient is not at risk for relapse. But if we don't intervene as soon as the PR3 ANCA rises again, then the patient is likely to have a subsequent flare. So we have custom-tailored our retreatment intervals based on B-cell counts and ANCA levels, which is different from the currently FDA-approved remission maintenance regimen, which is a repeat infusion every 6 months. So with that, I'll close and summarize. So the survival has improved dramatically over the last few decades, but the glucocorticoids, even though they're extremely necessary to acutely control disease activity, so far we have not been able to do without them. But we've probably on occasions been too generous with their dosing, and we're learning how to dose them better, and hopefully the new drugs will allow us to get by with much less glucocorticoids, if not without glucocorticoids in the early phase of the disease. Now, mepolizumab for EGPA, we'll hear a lot about this in the next presentation or in the coming presentation, is another very effective steroid-sparing agent for EGPA. That's where the biggest role is, to avoid steroids as much as possible in the management of EGPA. And I think the chapter on plasma exchange is effectively closed. We're not using it anymore at Mayo Clinic for patients. And with that, I'd like to thank all of you. Research really leads to these advantages that we've had over the last few decades. And research is a complex enterprise. It depends on not only motivated and interested colleagues who are willing to do the studies, it depends on a lot of money. And fortunately, over the last decades, we've been very fortunate to receive money from governmental agencies as well as support from industry who gets interested in these rare diseases. And the Vasculitis Foundation has done a tremendous job over the last few decades raising awareness, bringing interested colleagues together, bringing patients together, lobbying for funding, and overall increasing awareness and bringing all these forces together. But none of this would be possible without all of you, because participation in clinical trials is really crucial to move the field forward. So thank you all for being here and for listening. Thank you. I don't know whether we have time for questions, otherwise I'll be around.
Maybe a couple of questions so we can save time. Oh. I have a wife that's in her 3rd month and is down to, I believe, 30 milligrams of prednisone level. And her creatinine level has dropped down to about 1.3, I think it is. I'm wondering if there's a way I can advocate with her kidney specialist as far as making sure we keep the right acceleration of the prednisone, because she has had complications from it.
Yeah, I think this is a question that I'd probably rather visit with you in a little bit more detail on the side, because it is getting very quickly into very individual patient situations.
Is there a difference between what the FDA recommend on rituximab, the amount, and the rheumatologists overall? Is there a difference?
Well, so you're talking about, is there a difference in the dosing regimens? Yeah, so there are two major dosing regimens that are out there for induction. One is the one that is FDA approved for ANCA-Associated Vasculitis, which is the 4 weekly infusions of 375 milligrams per meter square. So patients get different doses depending on how tall and how heavy they are. And it's given as 4 infusions a week apart. The other regimen is a fixed dose regimen of 1 gram times 2 weeks apart, and that's the one that is approved for rheumatoid arthritis. Now, overall, we do not think that it makes a big difference in terms of efficacy. We do not have a head-to-head comparison, but whatever we know from looking at patients who've been treated with one or the other seems that there is no substantial difference. Sometimes insurance companies don't allow one regimen versus they allow the other, even though the rheumatoid arthritis regimen is certainly much more convenient for patients and it's actually cheaper. So the FDA-approved regimen is the 4 infusion regimen. If you get only 2 infusions 2 weeks apart, from an efficacy perspective, it probably doesn't make any difference.